This is the fourth, and I'm sure you're pleased to hear, the final part of the ACJ, ACJ and clavicle series for sports medicine. And in this part we're going to focus on the acromioclavicular joint. So this is a diarthroidal joint which has got a partial disc which pretty much disappears, and unlike the sternoclavicular joint really doesn't cause any issues. As we saw in the introductory talk, it really has minimal movement of 5 degrees of internal and external rotation, and its main function really is a connection between the clavicle and the scapula. Its stability is created by the strong coracoclavicular ligaments, so there's a trapezoid and a conoid ligament, and also the acromioclavicular ligaments, and I'll speak a little bit more about these and their function in the instability section. So the common pathologies associated with the AC joint are osteoarthritis, post-traumatic osteolysis, which is sometimes known as weightlifter's shoulder, and AC joint injuries, which are dislocations and subluxations. The imaging modalities we use are X-ray, and rather than a neutral view, the best view for the AC joint is sometimes known as a Zanker view, which is a 10-degree upshot. Really, that just avoids the scapular spine, which is present when you take a standard AP, so you get a better view of the distance between the top of the coracoid and the clavicle, which is sometimes important for dislocations, and also the actual clavicle and acromion. For the assessment of instability, an auxiliary view is essential. This is particularly good at looking for type 4 dislocations where the lateral end of the clavicle is displaced posteriorly intratrapezius. An MRI scan can be very useful for looking at damage to the coracoclavicular ligaments. It's also useful for looking at AC joint osteoarthritis and osteolysis, particularly with regards to what's happening to the rotator cuff underneath. So osteophytes occur not only superiorly, which can be felt, but often inferiorly. So along with AC joint osteoarthritis, rotator cuff pathology is not uncommon. CT scans are rarely used, and they tend to be used as reformatted and sometimes help with regards to instability. AC joint osteoarthritis tends to present with specific pinpoint pain over the AC joint. There tends to be a variable lump. It's not always present, so there sometimes can be some asymmetry from the other side, and this really represents superiorly an osteophyte. And as I mentioned earlier, you can have that inferior osteophyte, which can cause issues with the underlying supraspinatus tendon. Patients tend to complain of pain, particularly on cross-body adduction and on high arc elevation, so that's particularly in overhead sports, so racket sports and throwing. And as I mentioned earlier, they can sometimes have associated rotator cuff symptoms. As we mentioned in the introductory talk, osteoarthritis at both the SC joint and AC joint are very common. This is a study that looked at asymptomatic patients who had an MRI scan between the ages of 19 and 72, and they found that 68% of patients under the age of 30 had MRI evidence of osteoarthritis, and 93% of patients over the age of 30. So these are asymptomatic patients. So osteoarthritis is very common. You only need to treat it if it's symptomatic. On examination, patients have pain specifically over the AC joint on palpation and a variable lump with asymmetry. They have a positive scarf test, which is a cross-body adduction test where you're really compressing the AC joint. It's important to differentiate this on the O'Brien's test. They have a negative O'Brien's test. So the O'Brien's test is really looking for labral pathology. The arm is brought into adduction. For an O'Brien's test, the thumb is pointing down, and on resisted elevation, they will have pain if they've got labral pathology, but when the hand is then pointing out, that pain should disappear. If they have pain when the hand is pointing up, that suggests that they've got AC joint pathology, or the pain generator is coming from the AC joint. The AC joint is just above the superior labrum, so they've got a negative O'Brien's test. Patients, particularly older patients, may have associated rotator cuff pathology, and that's particularly with supraspinatus. Initial management for patients is activity modification, anti-inflammatories and physiotherapy. An ultrasound guided cortisone injection once again is diagnostic and therapeutic. In patients that fail this or have recurring symptoms, surgery is indicated. As we discussed in the second talk with regards to the sternoclavicular joint, the acromioclavicular joint is a unique joint. The lateral end of the clavicle is held rigidly in position by the trapezoid ligament, and that will actually prevent the clavicle moving laterally. So if you do an excision arthroplasty, which is essentially removing the about 10 millimeters of the lateral end of the clavicle, that space will be maintained. So the indications for an AC joint excision arthroplasty are failure of non-operative treatment. This is a procedure that can be done arthroscopically. It can also be done open. Patients often have associated cuff pathology, and this can be addressed at the same time. So you require 10 millimeters of excision, so you can either excise 10 millimeters of the lateral end of the clavicle. Sometimes, if you're a little bit concerned about that, you can actually remove an element of the acromion. The importance of this is you want to avoid any residual impingement, so you need at least a 10 millimeter gap to avoid impingement on adduction, and at the same time you're able to preserve the capsule. So this is an arthroscopic view from below. On the left hand side we can see the undersurface of the acromion where an acromioplasty has been done. On the right hand side the clavicle, and we can see up that the superior acromioclavicular ligament has been maintained and there's a 12 millimeter gap between the bones. Post-operatively, the joint is structurally stable, so there's no requirement for immobilization, and certainly with most sports, when they're able to return to play at 4 to 6 weeks. Contact sports a little longer, so I tend to say to patients that's more like 2 to 3 months. Post-traumatic osteolysis, although it has similar symptoms to osteoarthritis, is a completely different pathology. It's thought to be due to either an acute trauma or repetitive microtrauma and overuse at the AC joint. It's thought that this is possibly due to microfractures, fascial compromise, increased osteoclast activity, also synovial hyperplasia, and it tends to occur in patients where they're putting excessive load through the AC joint. So it's almost exclusively weightlifters, but sometimes you do see it in other sports, and particularly rowers. As a general rule, the symptoms have come on gradually and are almost identical to osteoarthritis, and they get particular pain whenever they load the AC joint, so particularly when they're doing bench press or an overhead press. On plain X-ray, their clavicle changes only, where they get periarticular erosions and cysts. And on an MRI scan, again, you just see changes on the clavicular side. They've got bone marrow and soft tissue edema, periarticular erosions, and in more advanced or longer standing cases, they can have joint widening. With regards to management, activity modification, which really involves rest for 3 months, has previously been recommended. This tends to be very difficult for most keen sportsmen, and in fact, if they go straight back to loading the AC joint, the symptoms just recur. Anti-inflammatories help acutely. In the acute situation, a diagnostic or therapeutic ultrasound-guided cortisone injection can give significant pain relief, and particularly for patients who have got a key event coming up, that can sometimes get them over the line. However, their symptoms often do recur, so for these chaps, surgery really is the best answer. Once again, it's exactly the same procedure as an AC joint excision arthroplasty for osteoarthritis. As I mentioned earlier, they're structurally stable straight away, so there's no requirement for immobilization. And most of these guys can return to light weight work at 4 to 6 weeks, although I tell them it's probably going to be 3 months before they're going to be actually lifting anything near their maximum weights. AC joint injuries in the form of subluxations or dislocations are one of the commonest shoulder injuries that we tend to see in athletes. Treatment can be a little bit difficult because the initial advice and treatment that we're recommending is often counterintuitive to patients. When they see the clavicle clearly displaced and you're recommending that you do nothing, understandably, they find it difficult to believe that this is actually going to give them a good functional recovery. The difficult thing is, traditionally, most treatment for AC joint injuries has been based on an X-ray classification. However, as I'll show you in a little while, there's unreliable agreement in classification between surgeons or doctors, and it's often not a good guide to treatment. So we can see these two images. So the one at the top you probably consider a type 5 dislocation, and the one at the bottom possibly a type 2, type 3. So this is the chap who had what was thought to be a type 5 injury 3 months down the line. He's pain-free and back playing Premier League rugby. The chap at the bottom who had a grade 2/3, 3 months down the line, he's in severe pain and wants surgery. So X-ray classification isn't actually the way that I tend to treat most patients with AC joint injuries. As we discussed in the introduction lecture, most of the movement for the clavicle occurs at the sternoclavicular joint. There's minimal movement at the AC joint, and the main function of the AC joint is to connect solidly the clavicle to the scapula. And this is done by a combination of mainly the coracoclavicular ligaments. There are two ligaments. There's the trapezoid ligament, which actually has two attachments, and it's responsible for 40% of the superior restraint of the clavicle going up. It resists compression, so this is the ligament that allows us to remove the lateral end of the clavicle without it collapsing down, and it also provides an element of anterior restraint. The conoid ligament, which is slightly more medial, is responsible for 60% of the superior restraint and also provides posterior restraint. There's an equal importance between the AP strength and the superior inferior strength with the coracoclavicular ligaments. The acromioclavicular ligaments are really condensations of the surrounding capsule, and actually their strength is far less than the coracoclavicular ligament. However, the anterior posterior AC ligaments are 3 times stronger than the superior and inferior ligaments. AC joint injuries occur due to a direct fall onto the point of the shoulder, so onto the acromion with the arm in adduction. What actually happens is the acromion is forced inferiorly, and that's an important point to remember when we look at the position of the clavicle in respect to the acromion. Of interest, 18% of patients who have an AC joint injury will often have a concomitant glenohumeral joint pathology in the form of either a slap tear or a Bankart. Traditionally, AC joint injuries are classified and their treatment based on X-rays, and the Rockwood classification is the most commonly used. However, there's a tendency to move away from this. In fact, the only one of the Rockwood classifications that I would base my treatment on is a type 4 classification, where there's been a posterior dislocation and buttonholing of the lateral end of the clavicle into trapezius. And there are a number of reasons for this. The Rockwood classification is an X-ray classification. However, we're looking at a soft tissue injury. It's actually the coracoclavicular ligaments and the acromioclavicular ligaments that have been damaged. There have been a number of studies that have highlighted the relative inadequacies of X-ray classifications when looking at soft tissue injuries. This study looked at MRI scan versus X-ray. There were 44 patients that had type 1 to type 5 dislocations classified on X-ray. However, only 55% of the time did the X-ray actually correlate with the soft tissue injury that was seen on the MRI scan. This study looked at the inter and intra-observer reliability of using the Rockwood classification. They had 10 surgeons, there were 28 plain X-rays, and they used 3D CT scans to confirm the actual position of the bone. So these surgeons assessed these X-rays twice, 4 weeks apart. What they concluded from the study was that there was an overall lack of reliability of the Rockwood classification of AC joint dislocations and their treatment, and there was an especially poor agreement between experienced surgeons. As well as X-rays not necessarily being a good indicator of the soft tissue injury, they may actually be measuring the wrong thing. So the Rockwood classification looks at the position of the clavicle. But as I mentioned earlier, the mechanism of injury is that the acromion is forced inferiorly. So has the clavicle gone up, or has the acromion or the scapula gone down? If we have a look at this picture of a patient from the front, if we actually draw lines, we can see that his clavicle, the tips of the lateral end of his clavicle in the AP view are at the same height. But actually, if we look at him from behind, we can see his clavicles are the same height, and it's in fact his scapula that has dropped down on the right hand side. So in this case, it looks as though it's not a case that his clavicle's gone up, it's the fact that his acromion has gone down, so his scapula has dropped. There's an increasing awareness that a lot of AC joint injuries are actually more scapulothoracic injuries. The sixth scapula, which I'm sure you will discuss when you go through the scapular session, which is a situation where the scapula is malpositioned, the inferior medial border is prominent, so that's a type 1 scapular dyskinesia. They've got coracoid pain and malposition with dyskinesia of the scapula, is an uncomfortable condition. In this study, they looked at 34 patients with chronic grade 3 AC joint injuries, and they found that 70% of those patients had scapular dyskinesia, and 58.3% had a sick scapula, and this was actually the discomfort they were complaining of. They didn't have particular problems at the AC joint itself. When treating AC joint injuries, it's important to take these factors into account. So the management considerations are that there's only a modest intra and inter-observer agreement on X-ray. There's only a 50% correlation between an X-ray and the soft tissue injury that's actually occurred. And it appears that Rockwood classification is not a perfect guide to treatment. And in fact, an AC joint injury is predominantly a scapular problem. The clinical presentation for patients with an AC joint injury is similar to a clavicle fracture in that they have pain, swelling and point tenderness over the AC joint. The arm is generally held in an adducted and supported position, and they have varying levels of displacement and skin tenting. Patients that have got a type 4 dislocation, so where the clavicle's gone posteriorly, may have problems with ACJ pain, so possibly a subluxosternoclavicular joint. And patients with a type 4 and a type 5 dislocation may have associated neck and trapezius pain. The way I treat AC joint injuries that I see in my clinic within a week of injury, I initially send them off for some scapular rehabilitation, and this is really trying to treat the scapular problems. So it's important that they have scapular assistance exercises and scapular setting exercises, and then I'll see them back in the clinic 4 weeks down the line. The vast majority of patients seem to be improving significantly, so I tend to call these coping patients. So I'll let them continue with their rehabilitation and then review them again at 3 months. There are some patients that really are just not improving at all, so these are the patients that I'm concerned and may be considering surgery. And in that group of patients who are coping, some return at 3 months and then they've actually dropped back and are no longer coping. So these are the group of patients that may require surgery. And in fact, it's a very small number of patients that actually end up with an operation. When it comes to surgery for AC joint injuries, there's some important factors that you should explain to a patient. There are multiple techniques that are used, which means there's no perfect technique. And in fact, the results following AC joint surgery, even the best results, often aren't perfect. Very different for fixing clavicles and sternoclavicular joints. The operation is mainly for functional recovery. They don't always get cosmesis, so it may well be that there will still be some asymmetry. And actually, the recovery from surgery is very protracted. The surgery tends to be very painful, and there's a minimum of 3 months before they're likely to be able to return to sports, and possibly 6 months for contact sports. It's important to compare that to patients that are able to recover non-operatively. So patients can return to contact sports within 6 to 8 weeks sometimes. So actually, patients that feel an operation will accelerate their recovery, that's not the case for AC joint problems. The other important fact to emphasise is the success of surgery is time independent. So if you do an operation acutely or you do a delayed operation, there's no difference in the outcome. So there's no advantage in rushing in to get an operation because you think you will do better than if you delay it. Thank you for listening. As I mentioned earlier, if you'd like to see more videos on any aspect of shoulder surgery and operations, visit my YouTube channel Cambridge Shoulder or go to my website cambridgeshoulder.co.uk.